Thank you for joining us with what's going to be a fantastic talk. Today, we're focusing on Parkinson's and how it can get in the way of exercise. We all know that we need to exercise to improve our symptoms, but sometimes it's just impossible because of dystonia, dyskinesia, and apathy. So, what should we do? Thankfully, we have Nate Coomer, physical therapist extraordinaire, helping us to walk us through this today. Nate Coomer is a doctor of physical therapy who has been working with neurological diagnoses as a physical therapist for over 10 years. He is the founder of the Parkinson's Fitness Project and a wonderful friend of the Brian Grant Foundation. Welcome, Nate, and thank you for joining us today. And I know it's going to be a good talk, so I'm just going to hand it right over to you.
Okay, thanks so much, Amy. It's nice to be able to speak to you guys today. I hope our talk is gives you some ideas, tips, and tricks to handle this kind of tough subject because I would say most of our patients deal with barriers to exercise. That's what we're here for as physical therapists. But the answers and figuring out how to get past those barriers is very individualized to each person. So hopefully the ideas that we give you today spur some creativity within you on ways to get the exercise that you need. And I'll just leave it at that. So we'll go ahead and take it away. I think I don't see my slides right now, but I think they're coming up. There they are. I had a feeling. So this talk is titled "When PD Gets in the Way of Exercise." I did a similar talk for Brian Grant a few years back during COVID, and I think some of the ideas still ring true. That was a tough time with everything shutting down, but the same some of the themes that we're going to talk about today are similar. So it's nice to be back. We can go ahead and move the slide forward one. So as Amy mentioned, my name is Nate Coomer. There's a bunch, I think sometimes the letters behind people's names get confusing. I'm a physical therapist and earned my doctorate of physical therapy from Northwestern back in 2006. I have my neurologic clinical specialty, which is that NCS. That's a test every physical, or when a physical therapist wants to specialize in a certain area, they have to take a pretty rigorous test. So that is, I decided to move into neurologic specialization a little over 10 years ago. And then over the last 8 years, we've been doing something called the Parkinson's Fitness Project. So just wanted to take the research that we knew was out there about exercise and how it helps us manage the disease and put it into practice as best I could, as best we could as our team now does. We have 2 physical therapy clinics in the Seattle area, one in Bellevue and one in Seattle. I'm in our Bellevue clinic today, and we try to help folks through individualized PT, group classes, and online training, which is the next thing you'll see, Daily Dose PD. We put up online exercises every week to try to give people fresh content so that they can have something to work out with when they're not in the clinic. I also have power certifications. Some of you may have heard of Parkinson's Wellness Recovery, a great group out of Arizona that kind of wrote the book on what we do as physical therapists for Parkinson's disease, and also am LSVT Big certified. So some of you may have heard of those letters before, but just want to make sure everybody understands who I am and what I do. You can move the slide forward one, Gavin. Thank you. So living well with PD. We try to promote that all the time here at the Parkinson's Fitness Project. It really comes down to a few important things. Staying consistent with your medications, staying consistent with your nutrition, and then really the important parts are, we know, consistent exercise, building strong social connections, and staying consistent with your routines. So we found that the main way to do that, oh, that's fine. You can go ahead and kick it forward one, Gavin. The main way to get our exercise in, to stay in a constant pattern, routine, that we aren't getting sidetracked with other activities. So we'll talk about that more. really living well, we know we can slow the progression of this disease, at least the symptoms of this disease, with exercise. And the reason that we're doing that is we're flooding the brain with nutrients and oxygen and blood to help wash out some of the byproducts that get stuck around in our brain with Parkinson's, those alpha-synuclein or Lewy bodies that you've heard of. And then we know when we are exercising, we can make better use of that dopamine that we know is depleted in Parkinson's disease. So those are the reasons why we need to exercise. But it really comes down to a few things that we need to remember when we're exercising that the research has shown us is super beneficial. So trying to get 150 minutes a week or more of intensive exercise, and that's different for everybody. But we want something that's getting our heart pumping and making us work, something that's complex. And we want to get that exercise in at least 150 minutes or more. So that's 20 to 25 minutes a day if you're working out every day of the week. And we know big movements, effortful movements matter. And that's all well and good. But sometimes the way we're moving with Parkinson's disease and the way we're feeling with Parkinson's disease gets in the way. So, we see this all the time in our clinic. Apathy is a big thing. And when I give these talks about the importance of exercise, oftentimes it's met with, well, it's really hard for me to get the motivation to get out there and exercise. It's really hard for me to want to get that exercise in each and every week consistently. And so we have to come up with ways to combat that apathy. You can move to the next slide. So this is hopefully not a picture of how you all are looking at me right now. I hope you all are engaged and excited to this dynamic speaker, but apathy creeps in. I've had that face before in college classes, I do remember. But it's defined as a lack of motivation, reduced goal-oriented behavior, and decreased emotional expression. We are not exactly sure why it enters in with Parkinson's disease. But we think it is a interplay of those neurotransmitters, dopamine and acetylcholine, that we hear about often with this disease. It actually affects almost 40% of people with Parkinson's. And it's one of the most common non-motor symptoms, along with fatigue and depression. So fatigue, depression, and apathy, not a perfect recipe for exercising vigorously day in and day out, right? We have some obstacles we have to get over. I found this study to be kind of interesting. People with Parkinson's that are reporting apathy actually tend to spend 2 times as much time on the television or watching television as those without. And it just speaks to the lack of, lack of motivation and reduced goal-oriented behavior. I also read one article when preparing for this that there was a study done about goal-oriented behavior with people with apathy, and how much like a monetary reward would work to get people to do something. In this study, it was exercise, and it was, they were giving out $1 for a certain amount of exercise, $2 for the same amount of exercise, 5, 10, and 20. They just kept going up. People without apathy would exercise for the recommended duration for $1 or $2. But for some folks, it took them almost $20 or $30 to agree to do that exercise. So you can see like the goal-oriented behavior goes down as well. So we need ways to supplement that. You can go ahead and go to the next page. So this is not like this is not copyrighted, but I kind of came up with this acronym RAGS. 4 tips to avoid apathy or to try to fight against apathy. We're going to call it a rags to riches plan. Not too bad. All right, so we need 4 things to really fight against apathy. We need to stay on a consistent routine. We need somebody to stay accountable to, because left to our own devices, we're going to be more likely to stay at home and not want to get out and get that exercise we need. We need goals. We need something we're fighting towards, and they need to be powerful to us. And we need to seek out support when we need that help. So we're going to talk about each one of these. You can go ahead to the next slide. So when it comes to routine, one of the biggest things that people with Parkinson's, um, you know, make note of when they're talking about the barriers to exercise that they have and coming up in a regular routine is kind of a perception of lack of time. It's one of the biggest barriers that they mention. And it's a perception of lack of time. And actually, we hear this all the time in here when we're trying to come up with routines for folks. And in all honesty, I have two kids. One's almost 13, one's almost 10. I have a job that I'm the owner of the clinic. I I know how this feels. I know how it feels to push away exercise because you think you have so many other things you have to get in. And so I don't think this is just a issue with Parkinson's disease. I think it's, life in general. As we get older, we feel like we have more things we're responsible for, and exercise is oftentimes the first thing to go when we're planning out our day. And so, and then there's two other areas that I'll get to later: feeling that we won't succeed and fear of falls. And so, kind of setting ourselves up in a safe situation and having easy ways to find some success earlier. But that perception of lack of time, if you can go ahead to the next slide, gets us out of our routine. It's the first thing we can kind of, like I said, the first thing you'll throw out. I'm going to wake up tomorrow morning at 6 o'clock and I'm going to get that run in that I promised myself I'm going to do. Oh, but I got to, I've got to prepare for my patients coming in, or I have a big talk today at noon for Brian Graham Foundation. So maybe I won't get that run in. So it's easy to move things around and push exercise out. Building that regular routine is what we're looking for, we strive for with our patients in here, finding time each and every day. And sometimes I think it can feel overwhelming for somebody to tell you need 150 minutes or more of intensive exercise. Let's go 30 minutes a day, just push through. Sometimes, if you haven't been on a regular routine, it takes between 20 and 60 days to build up that habit where your body feels like it needs exercise. We have to start slow and be consistent. So I always say, building a routine is not just about exercise. It's about your sleep routine, healthy sleep habits. That could be a whole other talk about sleep, and I'm sure Brian Grant Foundation has done that. But building that healthy sleep routine, building a healthy daily routine, getting up and getting going. A lot of our patients may or may not be working, but those that are not working, sometimes they struggle to get into the clinic any earlier than 10 or 11 o'clock because it's just, it's a process to get up and get going. But we really try to encourage people to get going early, get their breakfast in, get themselves, their hygiene routine in, and get going with the day so that they provide more time and more options for them to exercise. We've done certain things in the clinic that are super helpful, and they are not hard to get in a routine. One thing we do every January for our daily dose community, our online community, is simply we give out a 30-day challenge. And it's literally just a piece of paper with 30 boxes on it. And we're not asking people to go above and beyond. We're asking those folks that have fallen off in the last year to commit to 30 days of exercise. And it doesn't have to be 30 minutes. We're just asking for anything more than 10 minutes of movement every day for 30 days, and to document that, to write that down, because there is reward in seeing what you've achieved. And then we give out a raffle. It could be as simple as a few free months of daily dose PD, but we're trying to create that goal-oriented behavior so that people know there's some type of reward at the end. And this is something that anybody could do at any time. It doesn't just need to be January when everybody falls off. It can be for anybody, anywhere, anytime. We've given it out to patients in the gym, and I'm amazed at how effective this is, just giving something they can document every day and see their progress visually over time. I think that really matters. And the other thing that we always want to talk about with folks, and this will come up a couple other times throughout the talk, the medication cycle is also really something we have to work into our routine and be honest about. There are times throughout the day when folks are on or off. And, the research is really clear that when we're exercising, when we're our most functional, we get more benefit out of it, but we also feel better about the exercise we're doing. So if you're somebody that has a rough time in the late afternoon hours, we probably need to work that exercise in the morning or late morning. If you're somebody that struggles in the morning, we need to find time in the later afternoon for you to get that exercise in. You can go ahead and shift to the next slide. So that 30-day challenge, simply up above, it doesn't look anything. It's not difficult. It's not hard. This is just a copy of what we've given out. I encourage some of you that may be feeling apathetic to just give this a shot. Put out 30 boxes on a piece of paper. Give yourself a reward at the end, something that you're going to enjoy, a goal for you to achieve. We can talk about goal-oriented behavior a little bit later as well. But just a simple example of a way for you to start documenting your progress and see your progress over time. And that really is a positive feedback loop for your brain to keep exercising. Go ahead to the next slide. So we talk about accountability a lot. That is literally the only reason that I'm here as a physical therapist for Parkinson's, is to keep people accountable. Not the only reason. I guess there's other reasons, but I say this, multiple times a week. We know apathy, fatigue, and depression is baked into this disease. You need somebody that is here for you regularly. You have to check back in with, you have to report back to, and I'm happy to be that person. All of our therapists on our team are happy to be that person. I think even our online community. I saw Tim Wilson just shot a little chat in there. I don't know what he said, but hey, Tim. Tim is one of our regulars on our online community, and I know he's going to be there. I have to show up for him for that workout, and he has to show up for me, and he knows a few of the other guys, Keith and some of the other guys that show up regularly. He knows he's going to see them. It's that accountability that I think keeps people going. And we get this in all kinds of ways, but really the hardest thing is taking that first step to find your accountability partner, whether it's a physical therapist, whether it's an online class, whether it's a group class, whether it's a partner that you exercise with in the gym, which I have a patient this week who was asking me to help him find somebody that he could work out with. It was kind of at the same level he was and lived in the same area. And, I'm working hard to try to find somebody for him because I think it would really be effective. And somebody, I'm an extroverted introvert. I like being in these settings where I'm talking to people. I like my job where I'm interacting with folks. But when I get home, I'm very introverted. I kind of flip a switch. And this would be the hardest thing for me, is reaching out and finding somebody and having that person that you meet with regularly. It doesn't have to be every day, but once a week, once every couple of weeks, to make sure you're on the right path and you are not just allowed to go 6 months without exercising. Chris and Sue, great example. This was during towards the end of COVID. Sue was a regular on our online groups. Chris, we'd known in clinic and online. She was taking our classes pretty regularly for quite a while, but she fell off. She had some things happen to her health-wise, and she was having a really tough time getting back on an exercise routine. Sue offered to be that accountability partner for her on before we started one of our Zoom classes. She said, I'm going to be here every day and I'm going to be looking for you, Chris. And sure enough, that got Chris going. And every day they check in with each other. I'd hear them talking back and forth before the class started. And it's just an example of how that breeds. And slowly over the next few months, Chris turned into one of our most regular exercisers. So it can happen. It doesn't take much, but having somebody that you have to check in with is so important. It can be friends and family. We have a lot of patients that the spouse will walk with them, or they have a walking partner that's part of their family. A lot of times loved ones, siblings, and sons and daughters can be really, really motivating people, even if it's walking with them once a week or every couple of weeks. It keeps you going and keeps you moving in a positive direction. And then, I'll always, that's what group classes are all about. That's what the social support of group classes is so powerful. And that's why We always recommend them as much as we can when people get into work with us, when people are safe to join one. We want them in a group class so they keep that accountability going. You can go to the next slide. So that was your A. So we've got routine, accountability. There's a post test at the end of this. You guys don't know, but you better be taking notes, studiously taking notes. So we've got routine. What was the A? Accountability. And now we've got the goals, G, RAG, RAG. So we want to set realistic goals. When I talk to people, I'm a realist. Some people we have in the clinic, our 9 o'clock patient today, she has no problem exercising. She's exercised her whole life. It's no problem. She's an athlete. She's probably getting 250, 300 minutes exercising every week. And that's wonderful. But I know that's not the norm. A lot of people that come into our clinic and that I've spoken to, haven't exercised in years. Maybe exercised before they had kids, and then life got in the way and things fell off, and they haven't really been into a gym in years. So telling somebody to just start working out 150 minutes a week, even though that's it's doable, it can feel super overwhelming. And when we come to setting goals, I think the biggest thing is starting slow and building, starting reasonably and building. So I think it comes off tough when a physical therapist or a healthcare provider says, just kind of pushes the issue, pushes you. We have to meet people where they are and understand that everybody's coming from a different level, and then work with them slowly to build. And if you're somebody that's already been working out 150 minutes or more, then let's work on how to customize that and make that really specific to your symptoms. If you're somebody that hasn't been working out at all and gets diagnosed with Parkinson's and is having trouble with apathy, then let's have some really easy goals. Maybe we're going to go for 3 walks this week for 5 to 10 minutes. And you're going to write those down on your sheet, and you're going to come back to me, tell me how they went, give me your times. We're going to try to either increase the time a little bit, maybe add in an extra day, or try to increase your perceived exertion on those walks. We're not going to try to do more than you can handle right off the bat. And setting realistic goals for yourself is just as important. Realizing that Rome wasn't built in a day. As long as we start consistently, the biggest thing is consistent exercise over time with Parkinson's. We can build in the intensity later, but starting moving regularly is the biggest thing. And so we have to get going there, start there, and have some rewards. Like I said, we give out, free membership to our online class, t-shirts, water bottles, whatever it may be, to kind of keep people engaged. We also want you to reward yourself. If you've had a good week, if you filled out everything you set up for yourself in that week for exercise, treat yourself. Dinner out, a movie, massage, whatever that may be, give yourself those rewards. We're just like Pavlovian dogs. If we know there's something good coming at the end, we're all going to start to get excited about it and want to achieve that goal. And if you're looking for places to get in and find a fitness partner, find somebody that can help you out, we put up the link. BrianGrant.org has some great resources to help you meet those goals if you're looking to get in. Sorry. Next slide, please. So the last thing here, because we've got goals, we've got accountability, we've got routine. So we've got RAG, rags to riches. We need that S. That's seek out support. And I've got 3 P's in there. I'm sorry. I got happy with my P's in support. So seek out somebody to help you. Like I said, I'm introverted when I get home. I would have trouble going in and meeting a physical therapist like myself. I know that for a fact. I'd be the one where my wife would be saying, you got to go in and see somebody. And I'd still be sitting on the couch saying, no, I'm good. Don't be like Nate. Get in and see somebody. And it doesn't have to be an exercise specialist right away. If you are having so much trouble, that exercise just seems like something you can't even handle right now, getting in and having some support in this disease is important too. So even if it's a social support group, I have one patient that I worked with many times and became really frustrated because I could not get this gentleman to exercise outside of his classes with me. And he'd say it, I'm so apathetic. And it finally got to the point where I no longer asked him to exercise at home. I wanted him to just start to engage in the community. So I asked him to join a support group, an online support group for Parkinson's. And I thought, well, even if I get into even if he can engage socially on a regular basis, maybe this will lead to more. So, like I said, realistically, it doesn't have to be this overwhelming mountain of activities that you have to do. Maybe it can just be something as small as that: seeking out support from a doctor, from a support group, from a friend, from a physical therapist. Taking that first step and being honest with yourself and getting to the point where you can start to build on that. You're doing something consistently with that support, and then that can start to turn into a little bit of activity and exercise along with it. So you can always use briangrant.org to find more resources, to find those support groups and get the help that you need, or physical therapists. Like I said, a lot of times we are that support that people need to kind of keep them going and keep them accountable. So I've talked a lot about apathy here because I think it's really one of the most important areas obstacles that we deal with in terms of non-motor symptoms. So don't feel like you're alone in this. Don't feel like there isn't other people that are dealing with this or that aren't dealing. There's no one else dealing with this with Parkinson's. It's very prevalent. It's not your fault. We deal with it all the time. But some healthy ways to kind of counteract apathy: building a solid routine, sticking with it, finding somebody that you can be accountable to, getting those goals in place. It can be short term and long term. So starting off short and building to something much bigger. And then finding those support groups, support channels, whether it's group classes, online support groups, whatever it may be, to keep you going and moving in the right direction. Okay, next slide. I think I already talked about this, and I'll go through this again, but as a PT, we can also be that support. We do a lot of home program building in here. So even if it's just a couple sessions, don't feel like you're committing lifetime to your physical therapist. If you just want a few ideas to kind of get you going, we have a lot of patients that are independent with our home program, come back every 6 months just for a check-in. We revise some things and get them going on their own because they've become really independent with their exercise routine. And so they don't need us any longer, but we do want to always be that person to check in with. Okay, next slide. So Parkinson's and dystonia. We've talked about non-motor symptoms with apathy that can be barriers in exercise. Dystonia and dyskinesia we're going to talk about next. I know I can't see all of you out there, but I'm sure some of you deal with a little bit of dystonia. I want to make sure that everybody understands what that is. It's characterized as a state of abnormal muscle tone resulting in abnormal muscle contraction and or abnormal posture. So this can look many different ways. I gave a couple examples, and these are common, I guess, dystonic positions, postures, things that happen with some of our folks. Cramping in the feet, tightening in the feet, actually turning in of the ankle when people are walking. That happens quite often, where as they exercise, their ankle will start to turn in, and that becomes uncomfortable. Clawed toes, hammer toes, and this can happen in the fingers as well. But as you're doing something that's very, very complex, the toes can become curled and cause pain. I have a few patients that deal with something we call rooster arm, but it's really just the shoulders kind of going back and the hands going back as they're talking or as they're walking. It can throw them off balance, challenge, and can be painful and just uncomfortable. Oftentimes these dystonias become worse when people are doing complex activities. So moderate intensity exercise can bring some of this on, and that becomes a really big barrier to exercise, right? Who wants to exercise when it bothers you or when it hurts you? It's more common in young onset Parkinson's, and it can be positional or with certain activities. And that's really where we can come in. You can go ahead and push it forward one slide, Evan. As I was looking through this, again, almost 40% of people with Parkinson's describe dystonia as one of their motor symptoms. So you're not alone. It's not uncommon. There's some things you can do to manage it. The most conservative way that we talk about when we're working with somebody when they first come in is looking at routine. Again, that comes back again. Looking at their day, looking at periods of time when it's more consistent that the dystonia comes on. For some people, it's a time of day when they first wake up. When they first wake up, their toes are curled. It takes forever for those toes to kind of loosen up as they walk. Maybe it's at the end of a day of work, and when they're walking, that's when they're fatigued, they're tired, and that muscle dystonia takes over. And it can happen in any part of the body, as well as, I mean, it can be in the trunk as well. I've had people that have so much dystonia in their abdominals that it pulls them forward and pulls them into an abnormal posture of stoop posture that's hard to walk with. So it can be not just in the arms or in the legs, but also in the trunk. It can be associated with certain periods in your med cycle when you're going off from your on time. So the biggest thing I try to talk about is when people first come in is kind of tracking those symptoms over the course of a couple of weeks and really being diligent about writing down when their symptoms are the worst and when they're not, and trying to find those trends, because it can not only be helpful for me as a physical therapist to help them out with their exercise, but also helpful for the doctor. I think a lot of times people will come in and say, oh, my foot's clawing, my foot's turning, and they don't really have they're not paying attention to where it happens during the course of a regular day or with what activities. Sometimes just tracking those symptoms over time can really give the answers to what's causing the dystonia. It can be stressful situations that you're in. It can be certain activities, certain exercises, or certain times a day. And it might just be that a medication change or a change in medication dosage can make a big difference. But we need to track those symptoms first to see when it's happening and how it correlates with your medications and your activities. Next slide. So, these are still pretty conservative ways to manage dystonia. This is where PT and occupational therapy can come in as well. Like I said, medication management with your MD, so tracking your symptoms over time, realizing when they're the worst, when they're the most bothersome, and then working maybe with your MD to do a better job of avoiding those off times, or increasing dosage, changing around medications. That can sometimes be very helpful. Then meeting with a PT or a physical therapist or an occupational therapist, if it's in your hands and wrists, to modify workouts and specific exercises. So this is where I think I've seen the most benefit. I can think of quite a few examples where people were choosing an exercise that was causing dystonia over and over and over again, and it was driving them crazy. Maybe it was one patient in particular, Peloton biking. They were Peloton biking during the pandemic, and over time they started to develop a dystonia where their foot would plantar flex down as they were pedaling, and they couldn't get that normal plantar flexion, dorsiflexion push off, and then it became really, really uncomfortable. The calf started to cramp, and it would happen every time they biked. Now, we worked on thinking about different muscles, counteracting that one muscle group that wants to activate so much. So usually what's happening is when we do something vigorous with exercise and dystonia comes on, our brain is trying to work so hard, it can't coordinate all the muscle groups. And what happens is one major muscle, in this instance, the calf, was turning on too much and causing the foot to just push down all the time, and it never coordinated with the other muscle groups. So we worked a lot on phases of bicycling and phases of spinning that bike and different muscle groups to think about and engage and really connect with the mind and the body. And she was able to manage it a little bit better. We also had to add in some stretching programs before and after the bike so that she was inhibiting that muscle group. And then we also had to modify her exercise routine. She was an everyday cycler, and it just became apparent that this is causing so much pain and discomfort every time you do it. It's turning you off to exercise. So let's try swimming. That's what we did, and swimming went great. She didn't have any dystonia, and so it was a great compromise. Still getting the exercise she needs in, varying up her exercise routine so her body's getting a little bit more of a complex exercise pattern in, and she didn't have the discomfort that she was always dealing with. So sometimes it's about modification. Walking can be another example. Oftentimes people are using a certain muscle group, maybe in their ankle, and as they get more fatigued and they walk farther and farther, the ankle starts to work abnormally. Oftentimes it's a turning in or a turning out. And talking through what they should be thinking about. Think about rolling from your heel to your big toe. Push off of your big toe as you roll through. Sometimes those visual, verbal cues can be really effective at managing dystonia. And then we also, this last point, finding a safe place to exercise. I talked about stress and stressful situations causing more dystonia for some folks. And what I've talked with a lot of people is, we have one patient in particular who not just dystonia, but deals with freezing and fascination when he's in public settings, and gets very anxious. And I think that same heightened neurologic, heightened neurologic activity can cause more dystonia when people are in a place they don't feel comfortable. And so finding a place where you feel comfortable exercising is very important. Sometimes getting into a group class where everybody's dealing with the same issues with Parkinson's can be really helpful. Calm the nervous system down and allow you to exercise and move without so much dystonia, because like I said, what we're really dealing with here when we have these muscle cramping is a heightened neurologic system. Our neurologic system is just firing on all cylinders, and we need some ways to downregulate that nervous system. So finding a comfortable, safe place, maybe if you're going to a gym and you're not, you have some dystonia that you may feel uncomfortable about other people seeing, maybe you need to find a more private place. Maybe it's working with a trainer for a period of time, or working with a physical therapist where they understand the disease and they understand what's going on. Might help you to work through some of that, and make you feel a little less stressed. Next slide, please. So some ideas. These are pretty, when it comes to dystonia, it's really custom to each person. I put some extra slides on this, and I forgot, I didn't put them, I made a change this morning, so you probably didn't get it, Gavin, sorry. So we talk about competing responses a lot, and I kind of talk through that, like when I was talking about the gait and talking about the walking cycle and pushing through the big toe. But it's much like one muscle's hyperactive. So if I'm pulling into a extended wrist and hand position, which some of you may have noticed, like when you're walking, your hand pulls back. I see this a lot. Or your hand might ball up a little bit when you're walking, or your wrist might curl. Thinking about the antagonist, the muscle group that is being overpowered. So if it's somebody that, your hand likes to curl, or your wrist likes to curl when you're talking or when you're moving around, thinking about activating those wrist extensors, or maybe even keeping your hand in a bit of a wrist extended position, might be a competing response that will help that dystonia calm down in the moment, or at least fight against it. Because if our brain is getting all this feedback that this is the position we need to stay in, positive feedback loops continue to occur, and this will continue to happen more often. So we need a competing response, and sometimes that's just walking with our hand extended. Sometimes if our hand does extend, it's walking and gripping our fists. If we walk with an elbow flexion, if we're walking and our elbows flex the whole time. I have one patient that's very rigid He's doing great, but one arm, this is kind of his walking position all the time. So as he's walking on the treadmill, I'm trying to have him extend his elbow completely. Just keep the elbow extended to think about that opposite muscle group, get your brain to activate that muscle group during the activity that you have trouble with. Sometimes that helps to balance things out. So that's the competing response. We use that often in the clinic to try to find ways to modify the exercise. Stretching and gait mechanics. So stretching is a way to inhibit the nervous system. There's actually a lot of good research in stroke and other diseases that have much more tone. So a lot of times after a stroke, a person's arm will be super tight. Their neurologic system is just going all is pulling that arm into, it could be elbow flexion or whatnot, and they have a lot more rigidity. There's been good research to show that rhythmic stretching, prolonged stretching can decrease muscle tone and slowly improve things. Now, this is not something that happens overnight. You have to be very diligent about it. So, and work with a PT that knows something about stretching the correct muscles to try to come up with a good stretching routine that you can do before your workouts. And, when it comes to abdominal tone, I don't know how many of you experience this, but sometimes it can be something, it's called camptocormia, for those of you that might have gotten this diagnosis or told it's one of your symptoms with with the motor side of Parkinson's disease. It can be really devastating, pull you forward, and make it hard to move with gravity. So when you're standing up. So a lot of times we'll work on exercises that don't require us to be standing to eliminate that tone. So exercises on all fours, exercises on our backs, even swimming can be more effective seated biking than standing and walking. So we have to look at each person, understand where their tone is, and then come up with a plan that's specific to them. Go ahead and go to the next slide. Maybe. Now, some other ways that people have probably heard about. I'm not going to, these are a little bit less conservative when are still looking for answers. Some doctors will recommend Botox. It's really a neurotoxin that helps that cramping muscle. It's a small muscle. It's a small muscle group, can be effective, usually as a temporary fix for a number of months, but it can get us out of that kind of consistent pattern of abnormal muscle tone and allow the muscles to calm down a little bit so that then you can work on exercise and hopefully build strength in the muscles that counteract that muscle group. So if it's your wrist flexing, maybe Botox to relax it, and then working on the wrist extensor group can help to counterbalance things so that the dystonia isn't as severe after Botox. And it can also give pain relief. And then DBS is another option for folks that have a lot of rigidity and some dystonia. That's definitely a conversation for you and your movement disorder specialist. However, I just wanted to present those because they are other options in dealing with dystonia. Next slide. Now, Parkinson's and dyskinesia. So dyskinesia is a little different from dystonia in that it involves involuntary erratic writhing motions of the limbs, trunk, or face. It can be spasms of the face, it can be writhing shoulder, movements of the arm, trunk, legs. It's not a symptom of Parkinson's, but a medication issue generally. Okay, so most people don't have dyskinesia from Parkinson's. They have dyskinesia from either heightened medication usage to control their symptoms, or long-term medication usage. And so it can be very fluid. It can be a constant writhing that's very similar pattern over and over again, or it can be more jerky and erratic. Sometimes it can cause balance issues and that's where the obstacle lies, is protecting your joints from this constant motion and also protecting your balance when you're on your feet when you know you have these dyskinesias. Obviously, it depends on the medication and where you're at in your cycle. It can be more or less severe during your on times when you're getting your peak dose. of cinnamon or whatever it may be, and then it can be lessened when you're about to take your next dose because you're coming off of it. Next slide, please. The funny thing about dyskinesias is they're often non-bothersome, and the individuals would rather have them have the dyskinesias than be off completely and not um, and and have less movement, because oftentimes the dyskinesias allow them to move more freely, and so um, they'd rather have that feeling of a little bit extra movement than slow, stuck, and more rigid. But they can cause imbalance and increase risk for joint injury, so we really want to watch out for that and make sure people are protecting themselves as best they can. You can go to the next slide. So ways to manage, and this goes for dyskinesia and dystonia as well. We regularly point people to mindfulness and meditation videos. They don't have to be long. A 5-minute mindfulness or body scan video, you can find them on YouTube for free, as a way to, like I said, down-regulate the nervous system. If you think about dyskinesias as kind of your body's just moving a little bit too much, we need ways to try to calm the nervous system down. Just like with dystonias as well, we can use the same ideas. We use some neuroinhibition exercises. Now, stretching is one idea that we talked about. We also try to use breath control as a way to calm the body down, and hope, and then we also use grounding exercises. So I'll go through a couple of those in, I think, one more slide. Again, talking about medications with your doctors. Oh, sorry. Talking about medications with your doctors, coming up with the right cycle. Maybe you need to go down a dosage to see if it'll impact your dyskinesias and decrease the regularity and severity of the dyskinesias. And then working with a PT and OT. These are the same exact examples I gave before, but working with physical therapists or occupational therapists that understand movement can really help to give you some exercises that might help manage this disease or this symptom so that you can follow up and keep going with your exercise. Go ahead and go to the next slide. And I am going to try my best here to come out. And I'm going to come into the gym now. The big moment. So follow with me. I'm going to give you a couple examples of exercises you can do. I'll stay over here. All right. So let me get a tray. Hopefully you guys can hear me. Amy, can you hear me okay? So far. I'm going to try not to go too far away. Simple idea. When it comes to dyskinesias, we're trying to downregulate the nervous system. Sometimes exercises that get us on all fours can give us a sense of control, give our body a sense of stability, and kind of help downregulate that nervous system. So we'll practice a lot of exercises where we're on our hands and knees. Maybe it's gentle rocking and weight shifting back and forth. Maybe it's stability exercises where we're alternating arms and legs, controlling our balance. Maybe we're working on the ground if that's too hard, on our hands and working up. Modified push-ups back down to the stomach, reaching and rocking from side to side. There's the theory that the amount of weight and pressure we're putting through all our limbs can help to allow our body to find where it's at in space and calm the nervous system down. So we will work on a lot of those exercises in all fours. Even crawling forward and backward can help the brain kind of reintegrate and reorganize to slow down those dyskinesias. We'll also work on breathing exercises. So we know that people, when they're in a fight or flight response, when their adrenaline's really going, they can get more upright, more extended, and not allow themselves to get all the air out. And when we can fully exhale, my wife works a lot on this with her runner. She's a physical therapist too. But when we can fully exhale, it helps us to down-regulate and calm the nervous system down. So we'll work on it in a lot of ways. Sometimes it's just as easy as on our back. I don't have a wall here, but on our back, we put our feet up on a wall. We'd find pressure on our feet, and then we work on fully blowing all the air out of our body, engaging our hamstrings, engaging our core, and then a nice gentle breath back in. And we can do this in many different ways, on hands and knees, with our back against a wall, where we're trying to work on breath control and full exhalation to calm the body and nervous system down. So a couple different ideas of ways we work to, like I said, calm things down and stabilize the body. We also try not to work with a lot of free weights in class. A lot of times we use resistance band. That provides a more constant resistance and a little bit more stable surface to work from. Sometimes when somebody's having so much trouble, we need to stay in sitting as opposed to standing to avoid, avoid safety issues and balance issues. But working on a seated bike instead of walking might be another modification that we need to do. Anything we can do to keep people exercising and moving, but it's important to see a physical therapist to really understand what you can be doing safely. I'm not sure if I had any other slides there, Gavin. I think I was pretty much done. Just wanted to give a little bit of a demo, and then, final thoughts. Routine, routine, routine. You've heard me talk about this a lot, but getting into a routine and deciding to stick with it. Find a safe environment where you feel comfortable and accepted. Seek out physical therapy assistance, occupational therapy assistance, support group assistance. If you're dealing with obstacles and, working with your medication cycle is really important to find out when you're at your best so that you can exercise at your best. Remember, routine, accountability, setting goals that are realistic, rewarding yourself for those goals, and finding that support you need is really, I think, the most important factors in kind of getting over these obstacles and keeping exercising. So I think the last slide has my information. If anybody wants to contact us, you can reach out to me at nate@theparkinsonsfitnessproject.com. Our phone number is listed below. And I'm more than happy to take any questions you might have. Thank you for your time.
Thank you, Nate. That was amazing information. I got a little tip I'm going to add in too. So for that rags to riches is being prepared ahead of time. So if I say, I need to work out tomorrow, I make sure the night before I have my exercise clothes set out. I've got my shoes. I've got whatever plan I want to do in place, whether it's, a daily dose video tagged and bookmarked, or, I'm going to walk. I have my path planned so that the next day I don't have an excuse not to do it because it's all been prepped the night before. But anyways, back to questions. Some came in, but you really, I think, answered a lot of them during your talk. But one was just managing general muscle pain. So not necessarily Parkinson's pain, but on top of that, what would you recommend?
So if it's like a kind of a general chronic muscle pain,
that or maybe like the muscle soreness post workout.
Oh, okay. Well, chronic pain is also a common symptom of Parkinson's. So we deal with a lot of that, a lot of those same complaints in the clinic. And there's multiple ways to get around it or deal with it. Some work for certain folks better. If it's just one muscle group, we can work on specific stretching, targeted stretching, maybe even using self-massage techniques, the Theragun or heat or ice to kind of break up those pain signals that are happening between the brain and the muscles. If it's a more of a whole body chronic pain that comes after exercise, maybe it's modifying the type of exercise you're doing. Maybe some exercises for folks are a little bit more aggressive or can bring on more pain. So we first would try seeing if we can modify the exercises, and then it might even be some compensation techniques like a regular massage. Things that make the body feel good. And we have quite a few people that get in to see a massage therapist every couple of weeks. It's a little added expense, but it sure does do a nice job in controlling some of the pain that they have. Like I said, if it's a specific group, getting in to see a specialist and kind of working through how you can stretch that out, things you can do to manage the pain after exercise are usually pretty effective.
It's great advice. Somebody asked if stretching can trigger dystonia. I know you mentioned that it's helpful with relieving some of that, but can it trigger?
It's generally, I keep using that word, neuroinhibitive. It generally down regulates the nervous system, gentle stretching. Now, the thing that most people don't understand is stretching needs to be held for a long period of time, like 45 to 60 seconds in one position. People think of stretching as kind of rocking in and out of a position, but if you're really going to stretch to lengthen the muscle tissue and downregulate the nervous system, it needs to be held for a long period of time. A slow, prolonged stretch that's not aggressive. So if you're stretching really, really hard, I keep talking about this nervous system, but you're going to excite the nervous system and things are going to get worse. So it really needs to be kind of a gentle, comfortable stretch for a
Great.
long period of time.
Well, I think that's it. Like I said, we had some questions come in, but I feel like you answered them during your talk. So thank you so much. I really appreciate the takeaways, the advice on the reward chart, and then demonstrating some of the exercises and positions we can do to counteract some of this. And the most important thing, everybody, is just get out and move. So
Mhm.
thank you very much, Nate. Appreciate it. Everybody else, thank you for spending your time joining us today, and go out and move. We'll see you next month. Thank you.
Thanks.